So moving next, we have two interesting case presentations now. The first one is a patient with a poor lung function who's planned for minimally invasive esophagectomy. So this will be presented by Dr. Jurgens. He's a consultant in anesthesia and intensive care, Norfolk, Norwich Hospital, United Kingdom. So Dr. Jurgens, screen is yours.
Well, thank you very much for the invitation to speak. We've heard the sort of broad concepts and the brushstrokes. And so over the next 5 minutes, I'm going to give a presentation on a patient with poor lung function, COPD smoker, for minimally invasive esophagectomy with obviously who went through prehabilitation and enhanced recovery after surgery. Now, I work in the same hospital as Ed, and hopefully this will be proof that he actually does what he says we should do and not just says we should do it. I've had the privilege of listening to the previous speakers, and I think our management is pretty much on track. So without further ado, this patient, I'll just get control, hopefully. There we go. 70-year-old male with a normal BMI who was diagnosed with a poorly differentiated adenocarcinoma of the distal esophagus after he presented with dyspepsia in 2016. So it's a few years ago. He was still smoking, had a 50-pack-year smoking history, and although he was on 2 inhalers via his general practitioner, he hadn't had any formal respiratory investigations done. So following diagnosis and cancer MDT workup, he underwent neoadjuvant chemotherapy, and at the same time, he was started on his preoperative optimization with smoking cessation, an exercise program, and then additions to his diet in the form of vitamins and iron. And plans were also made to investigate his chest more thoroughly with lung function tests and cardiopulmonary exercise testing. Now, the thing of note there is that the anesthetic pre-op assessment only happened 3 days before his operation. And this probably highlights the fact that from the time of diagnosis, optimization should start. Now, there is an audience poll, which I hope will be displayed for you to vote, but it's about the FEV1 values that you'd be happy with, the anaerobic threshold values. So if you continue voting with that, and then we'll look at these results at the end. And also a question on whether you'd use systemic steroids after minimally invasive esophagectomy and your habits with antibiotic use after esophagectomy. So what did the lung function test find? It confirmed that he had severe COPD with a 0.94 litre FEV1, which was 35% of predicted. And in the center there, we can see the characteristic obstructive flow volume loop of COPD. And I also added a slide of his esophageal CT, which demonstrates the emphysema in his right lung, where the red arrow is. Cardiopulmonary exercise testing had to be stopped at 7 minutes for this patient, but what it did show was ventilatory limitation because of his obstructive airways disease. Now, the 9-panel plot is not particularly clear there, but what it did conclude is that his VO2 max was 16 with an anaerobic threshold of 11.2. Now, these numbers are not necessarily predictive of outcome, but numbers of 16 and 11 are used as discrimination for patients needing more enhanced monitoring and management post-operatively than the ward can provide. In Norwich, all the minimally invasive esophagectomies do come back to the HDU post-operatively. So what happened with this patient? On the day of surgery, he underwent minimally invasive esophagectomy by Mr. Cheong, and the anesthesia was delivered by Dr. Francis, who we've heard from there. And analgesia comprised spinal morphine at the halfway mark, a surgically inserted paravertebral catheter through which local anesthetic was infused for 4 days post-operatively, a morphine patient-controlled analgesia device, as well as regular intravenous paracetamol. Now, that chest x-ray on the right is taken at 8:05 in the evening on the day of his surgery, and you can see the right lower zone basal atelectasis there. One can also see the chest drain on the left and the drain on the right, as well as some subdiaphragmatic air, which you'd expect after surgery. His first night was disturbed and disrupted by breathlessness. He had a poor cough, increased sputum production, and quite a prominent wheeze, for which he received nebulizers. Now that's the drug Gantt chart out of his electronic record. And at the bottom here, we can see that he received saline, salbutamol, and ipratropium bromide nebulizers regularly. But by 48 hours post-op, where his symptoms of COPD failed to resolve, I had a discussion with Mr. Cheong early in the morning, and we decided to introduce intravenous systemic steroids in the form of hydrocortisone, which after 3 days was converted to prednisolone when his oral route was assured. Now, what do we do with antibiotics? Normally, we just administer 2 post-operative doses of a broad spectrum, coamoxiclav in this case. You can see one on the night following surgery and one the following morning. But in this patient with his at-risk chest and also with his increased sputum production, we made a decision to introduce empirical piperacillin tazobactam. Now, this is not very clear, but his white cell count peaked at about 17 and wasn't particularly impressive. And his CRP also went up to about 300 and then turned and came back down again. So one could argue whether antibiotic or more potent antibiotic therapy was required. What else happened on the HDU? We weaned his inspired oxygen concentration, and the emphasis was on mobilizing. So initially on day 1, he did standing and stepping. He sat out in a chair, and this progressed to the point on day 3 where he was able to do a lap of the HDU, assisted by the physiotherapy team. And it's also not uncommon to see our surgical team come, and as Mr. Cheong said in his talk, to come 2 or 3 times a day and encourage patients to mobilize. What else did the physiotherapists do? They carried out respiratory therapy in the form of active cycle of breathing techniques and forced expiratory techniques to expectorate phlegm. Now, the key to this is in the top over here where the asterisks are. We can see this patient's pain scores. Now, that's a sort of 8-hourly pain score, but if we look, it varied between 0, no pain, and 1, mild pain. And this allowed the mobilizing and the respiratory therapy, which is crucial in these patients. The X-ray on the left at the bottom, this one is day 1 post-op, and true to his word, Mr. Cheong has removed the left-sided chest drain. We can see there's still a bit of the basal atelectasis remaining, and by day 4 post-op, the X-ray on the right, we can see that the basal atelectasis has all but resolved. So following his discharge from the HDU and then finally from the hospital, the prednisolone was weaned down by 5 milligrams per day per week over a sort of 7-week period. There was the standard thromboprophylaxis. He had some surgical interventions, which I understand are not uncommon after minimally invasive esophagectomy. And I've added the CT scan on the right. There's some coronal and transverse views. This is 2 years of following his surgery. And while it excluded recurrence of the cancer, it does unfortunately look as though the emphysema is slightly more prominent. And unfortunately, this patient started smoking again. Mr. Cheong has reviewed him 2 months ago in the clinic. This is about 4 years post-op now. And he's functioning well still with good exercise tolerance and with minimal symptoms. And he also gave us permission to talk about him in this case presentation. What are the key messages I could give you? Now, we've heard the broad brushstrokes in the previous talks, but the key things are optimizing the patient as soon as the diagnosis is made, not waiting to the point where they get to see an anesthetist, which will be very late in the day or very close to the time of surgery. Communication and teamwork. Decisions like giving systemic steroids, for example, in the patient immediately post-op with increased infection risk, et cetera, are difficult. And so teamwork is important. And then probably the key, as Dr. Francis pointed out, is effective analgesia, which allows the respiratory therapy and the early mobilization, which makes a difference in these high-risk patients. So in retrospect, in this patient, obviously the sort of outcome has been good, but hopefully with optimization and with enhanced recovery after surgery, these borderline high-risk medical patients, maybe more of them could benefit from surgical cures for their esophageal cancer. What I'll just do is hopefully bring up the results of the chat of the poll. Our patient had less than 1 liter, so 6% of people might have been unhappy to proceed with surgery in this patient. So well done to Mr. Cheong, I suppose. The anaerobic threshold, we can see here that more than 12, and this one was slightly less, it's probably sort of 50-50. no, and a big no at 90%, would you use systemic steroids? And I suppose on a case-by-case basis, ideally you wouldn't want to give a high dose of systemic steroid to a vulnerable patient immediately post-op. And the other thing would be, do you routinely use, or how do you use antibiotics on indication only? And that is our practice as well. But in this case, because of his comorbidity, we obviously decided to escalate antibiotic therapy. I thank you for your attention and questions. Thank you very much.